Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I am talking to Dr. Eduardo Sanchez, the Chief Medical Officer for Prevention at the American Heart Association. We discuss the intersection between the risk for cardiovascular disease and the risk of serious illness or death from COVID-19, and what it means for the kinds of changes needed in our healthcare system and in our society. Let's listen. Dr. Sanchez, thanks so much for joining me. From your position in the American Heart Association, when you're looking at what's happening with COVID-19 right now, what's top of mind?
Thank you, Josh, for having me. Let me start with this. I am the Chief Medical Officer for Prevention at AHA, but my background is in family medicine. I'm trained in that, but I'm also a public health doc. I was the local health officer in Austin, Travis County, and I was the state health officer in Texas. So from the beginning, literally from the beginning, I've been paying attention to what was going on with the 2019 novel coronavirus. And the American Heart Association actually had a first weekly webcast to our staff about what now we call COVID-19 in late January. So we've been tracking this. One of the things that we noticed very quickly from some of the preliminary observations in China was that age was a predictor of a higher case fatality rate, but so were having underlying medical conditions. And among those that were called out were cardiovascular disease, hypertension, type 2 diabetes, all three risk factors for cardiovascular disease of interest to the American Heart Association.
And these are all problems that are not uncommon in the United States. Would that be fair to say?
They are very common in the United States. It would be fair to say 120 million Americans have cardiovascular disease. But what's different from the United States, at least at face value compared to China, is that the United States is a diverse country where for decades the American Heart Association has known that there's a disproportionate burden of disease by race ethnicity. A set of quick examples. The cardiovascular disease mortality rate among African Americans is off the charts higher than that of virtually every single other group. And while over the last decade, there has been a decline in mortality for every single major race ethnicity group in the United States, where African Americans have ended up at the end of those 10 years is still higher than where the other groups started 10 years ago. Same is true for stroke.
So when you saw the information that COVID-19 was more likely to be deadly in people with cardiovascular disease, did a light bulb go off like this is not going to be good for example, African Americans in the United States?
I think a different way of saying that is that at the American Heart Association, we were not surprised when we saw that there was a disproportionate fatality rate among African Americans. And now we've seen that also for Latinx, and we've also seen that for American Indian, Alaska Natives. Fatality rate, likely to be hospitalized, likely to end up in intensive care. All of those disproportionately higher for those groups compared to other major groups in the United States.
So let me ask you this question. Why? Why is it that those groups have such high rates of cardiovascular disease and as a result are at such greater risk from COVID-19 infection?
There's a few things, and we could sort of slowly go upstream, if you will. So one is, if we look at hypertension as an example, it's a good example. The prevalence of hypertension among African Americans substantially higher than that among other groups. Hypertension is a risk factor not only for cardiovascular disease and stroke, but also some of the other things that are in the category that really raise the likelihood of bad things happening, including end-stage renal disease and more in the family, if you will, congestive heart failure, otherwise known as heart failure today. The other is type 2 diabetes. So type 2 diabetes is more prevalent among African Americans, Latinx, American Indian, Alaska Native. Those two things raise the likelihood of having cardiovascular disease. And again, they by themselves are related to having a higher case fatality rate. Now, if you ask the question, which I'm going to presume you would ask, is why is that the case that hypertension and type 2 diabetes are more prevalent? One can go a little bit further upstream and recognize that there are lifestyle factors, as we call them, behavioral factors, what you eat, and how physically active you are, which contributes to a different condition, the likelihood of obesity, and those are unfavorable among African Americans, Latinos, and American Indian Alaska Natives. So I'll stop and take a breath, because then the next step up is, why is that the case?
Well, I'm going to ask no, I appreciate that. And I am going to ask that question because some people just stop there, right? Some people say, well, it just has to do with the smoking rate or something like that. And that's it. That's the final point of analysis. But I want to push you a little further and say, what is the reason for that different risk factor profile? And how do you think about that at the American Heart Association?
Sure. And I think that in the same breath or in the same sets of comments, I'm going to do a little bit of convergence back to COVID-19, because it's a set of socioeconomic factors that are associated with these more downstream lifestyle issues and then the manifestation of disease. Which socioeconomic factors are we talking about? Well, one of them is going to be, if we talk about social determinants of health, one is the likelihood of having insurance, which if you've got high blood pressure or type 2 diabetes early on, you really don't have any symptoms. You wouldn't know unless you were in contact with a healthcare system to get things tested and then addressed early, whether that's a lifestyle intervention or being put on medications. And the earlier you know that something's going on, the less likely it is that it's going to progress and lead to really bad things.
So as it just to jump in there, as an example of that, if you had good access to healthcare, you might be able to get counseling and medication, for example, for smoking, and then stop smoking, as just an example.
That's exactly right. So if it's smoking, not only told that it's a bad thing to smoke, but connected with the resources that will help you quit, which, we know there is a science base for how you do that. Just telling people a lot is not one of those science-based ways, but connecting them to the resources. The same goes for healthy eating and physical activity and even weight management. That is, having access to care allows somebody to, give you the nudge that maybe this needs to be taken care of, and then connected to the science-based resources that might make a difference. But that's just but one of the socioeconomic factors. The more critical ones really are even further upstream, and they are both immediate and longer term. The immediate is what kind of work you do and what your income is. So if your income is that some kinds of work don't offer insurance, so that's one reason why that's important. And then other kinds of work don't pay you very much money, and your ability to, example, eat healthy foods and or participate in physical activity may be restricted on the one hand because you don't have the money. With physical activity, it may be you don't have the time or the energy to do the things that might keep you from being sedentary when you're not on the job. And then the other is educational attainment. There is very, 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 very compelling evidence that education beyond high school, even 1 year of education beyond high school, vocational training, makes a difference in mortality rates, which may be due to the kind of job you have, the kind of income you have, and the kinds of the ability to think through what are the things you need to do to achieve a long, healthy life.
So Dr. Sanchez, are you saying in part that the kinds of factors that people have talked about as putting people at risk for COVID-19 disease, and I'm talking about living in crowded environments, not being able to isolate, not having the money to stay away from other people for a period of time and having to go out to get food and other things. Those are, clearly risk factors for getting COVID-19. But are you saying that those sorts of social risk factors also relate to why some people have chronic illnesses like cardiovascular disease that make it more likely that people will die when they get COVID-19?
That is exactly what I'm saying. And so there is at least an additive, if not a multiplicative effect of the circumstances that put you at risk if you have COVID-19. Because let's go through those. If you don't have health insurance, you might not be able to go get tested as soon as you would have liked. You might not have a place to call and say, I'm worried that I have COVID-19, and get that addressed by a health professional. If you are in a high-risk housing situation because you don't have the money to live in the expanse you need either for 2 or 3 families or multi-generational, your ability to social distance is challenged. But if no one was leaving the house, that might not be the worst thing in the world. But if, in addition to all of that, you still happen to have a job, because the other thing is you're more likely to have lost your job if you're in the categories that we just talked about, and then you have to venture out in the world to figure out how you're going to get food through the services that, thank God, are available to sort of get by. But even if not, if you're a quote unquote essential worker who is a bus driver, or you're working a meatpacking plant, or you are clerical staff in a hospital where they are trying to figure out how best to ration personal protective equipment, you are at higher risk. So that plus cardiovascular disease, underlying cardiovascular disease risk, more likely to get it, more likely to have a bad outcome if you get it. That's a bad combination.
Yeah. So if we think about the challenge here of the risk of getting it and the risk of a bad outcome, it's some of those same social factors that contribute to both. And you wind up with the higher risk of a bad outcome in part because of the likelihood of cardiovascular disease along the way.
That's exactly right. And in the world, in the post-COVID world, when we try to figure out how we make things better for the next time we have to deal with a pandemic, preparedness is but one part of how we need to think about this. We also need to have in play these policies and attention to the socioeconomic variables that will affect the underlying health of a population. We have to think about how we protect people in the workplace in the midst of a pandemic. And we need to think about how we better treat and provide access to care for persons who actually go on to develop those underlying medical conditions.
Great. So that brings me to my last question, which is there anything that we can and must be doing now to prepare for that shift? Understanding that there's a lot that needs to be done to get to some of those issues, and that should be a very high priority when we're past the pandemic. Now that we're in it and we're trying to protect people and save lives, what are the kinds of things that are the top of your list for what should be done?
I believe that we need the same sense of response post-COVID to come together as a set of stakeholders in our country, starting with the people who live here, but including employers, including the government sector, including the academic sector, including businesses that maybe never thought they were related to pandemics, food system, health system, entertainment business, come together and think through what does the health and healthcare system of the U.S. need to look like in order to preserve those things that we think are important, the health and well-being of our nation and the economic viability of our nation. And I think it'll take almost a post-World War II approach to get it done at the highest level of a McCarthy intervention.
Almost like a Marshall Plan, in other words, for public health.
Yeah, Marshall is what I meant, but I couldn't come up with the M word, so it is the Marshall Plan.
I think your point is very powerful, and we are seeing the results of our failure to have done that, and hopefully a pandemic can create the momentum to address some of these issues and prevent further suffering in our daily lives, essentially.
Absolutely. And just to repeat, Marshall Plan. We need a Marshall Plan approach, which really was about many countries across the world and many industries saying, this is so important, we're going to figure this out. This is so important, we need to figure this out.
Great. Well, thank you so much, Dr. Sanchez. I really appreciate your joining me. Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.